You guys ready? All right, I'm Eli. I'm a senior. It's my senior lecture. Like a lot of us doing senior lectures, I had a little bit of trouble deciding exactly what to do. Initially, I thought, why don't I rehash our protocol debate from last month with Kenny, but Kenny's not here, so that seems unfair. Then I thought, why don't we go through the 2021 AHA guidelines line by line? But that's not really fair to you all. And so I decided on something that all of the seniors next year will likely have to work with, and things that we don't necessarily learn in our residency to the degree that maybe we would have to deal with it outside. Advanced practice providers. So this is a topic that we have some familiarity with in fast track, but I'll kind of go through different practice models and ways that it exists outside of Kings County. I'm going to kind of center this around some cases, around 5 cases, which I'll introduce to you in the beginning, go around some background issues, the trends of APPs in emergency medicine, always talking about money, staffing issues, our liability, and then we'll go through those cases again. And like any good senior lecture, it ends with a shameless photo drop. So I want to be very clear about what this lecture is not. So this lecture is not an argument for or against APPs in the emergency department. And it's not an argument for or against independent practice by APPs. Those are topics that are huge and different and require their own lectures and their own kind of dive into literature and what's going on. So let's start with these 5 cases. So these are 5 real cases. I will introduce to you the kind of facts of the case, and I want you to think about who is liable, who is responsible based on what you know now. And hopefully by the end, you'll be able to kind of get what the case actually concluded. So case 1, this is in Pennsylvania. This is a 2-year-old boy who has a high fever, has URI symptoms, is seen by a PA in the emergency department. The x-ray shows pneumonia like this one. This is a stock photo, obviously not the actual case. The parents wanted this child hospitalized, the PA discharged with antibiotics. The MD did not see this patient, did not sign the charts, and the patient actually came back to attempted to come back to the hospital but the next day, but died en route of respiratory failure. Case number 2, this is in Wisconsin. This is a patient that developed flu-like symptoms after a root canal. There is a documentation in the charts that the patient had a bicuspid aortic valve that did not receive antibiotics prior to the root canal. Was seen in the ED by a PA who did in the chart note the cardiac history as well as the dental history and discharged without any workup or any antibiotics. The MD in this case reviewed the chart and signed the charts. The patient decompensated over the next few months and ended up dying of endocarditis. Case number 3, this is a Maryland case. This is a young gentleman that came in complaining of cough and fever. The PA saw the patient primarily in the emergency department, noted no concerning findings, however, had a documented temperature of 102 and a respiratory rate of 26. The patient was discharged prior to the physician ever seeing the patient, was brought to another emergency department 12 hours later, intubated for respiratory failure in the setting of multilobar pneumonia. Case number 4, also a Maryland case. This is a 58-year-old gentleman coming in with abdominal pain. The PA saw this patient initially, ordered x-rays, pain medication, including opioids and blood work. The blood work came back with a white blood cell count of 14,000. The ED physician did see this patient after this workup was initiated. The PA communicated that there were no abnormal lab findings. The patient was discharged and ended up returning 6 hours later to a different ED with perforated appendicitis. Case number 5, our last case. This is in Alabama. This is a young woman presenting with abdominal cramping, nausea, and vomiting, seen primarily by a nurse practitioner diagnosed with gastroenteritis. No blood work was done, was discharged. The supervising physician did not primarily see this patient, but did sign off on the charts. And the patient died 2 days later of a ruptured appendix. So now we're going to go through the rest of this lecture. And I want you to kind of use these cases to think about who actually is liable, who is responsible, and we'll come back to them at the end to go over the case conclusions, okay? So what is an APP? So an advanced practice provider, also known as a physician extender, a mid-level provider, an allied health provider, or a non-physician provider, is actually a pretty wide range of providers in healthcare. In emergency medicine, we often see PAs and nurse practitioners, or APRNs. However, in the anesthesia world and in the rest of the hospital, there are other APPs such as CRNAs and certified nurse managers. APPs really emerged around the 1960s, initially with PAs. They were a response to shortages in primary care. It was initially a 4-person cohort that then kind of grew and grew into all of the PAs and NPs that we see now. Interestingly, the growth of APPs was accelerated by the duty hour restrictions on residents in 2004 by ACGME. And I want you to think about the fact that there's actually still a pretty big shortage in primary care in this country, even though we don't see it in emergency medicine. The APP still uses primary care shortages to kind of grow the fields. So let's start with a nurse practitioner. This is a registered nurse, master's in science or doctor of nursing practice, who's obtained some kind of specialty training. Average education is 15 months to 2 years, and around 720 clinical hours to graduate from a nurse practitioner school. For comparison, the average medical student is about 6,000 hours in school, and residency is about 10,000 hours. The laws and regulations regarding nurse practitioners are pretty varied in different states. So the dark blue states are states that allow for independent practice of nurse practitioners. The kind of middle blue does not allow independent practice, and the light blue is a collaborative agreement between a nurse practitioner and a physician or a DO. The one, Illinois, which is white, is a collaborative agreement, which is a specific site and has these very strange regulations. Kind of mirroring that, the ability to independently prescribe medication is pretty much followed. You know, if there's independent practice, nurse practitioners are allowed to prescribe medication independently. Physician assistants. So these are licensed professionals that are specifically trained in a PA school as part of a physician PA team. The average education is just over 2 years with 2,000 clinical hours. The laws and regulations around PAs are also pretty varied by state. So this is actually from the American Association of Physician Assistants website, kind of showing the different laws and regulations through all these different states. It's actually quite a fun wheel to go through. So in New York, for example, PAs have full prescriptive ability. They actually have scope of practice determined that's different at each level. You don't need to sign off on every chart, kind of is determined at the practice level. And there's no real limit on the number of PAs that a physician can supervise. Whereas in Pennsylvania, for example, those laws are quite different. You can see here that they're not the same as they are necessarily in New York. And all throughout this wheel, all throughout the country, those laws and regulations are changed based on a state-specific region. Just kind of looking at a slightly more granular example of New York, Illinois, and California, you can see that these laws and regulations are pretty detailed and pretty different. So while a co-signature is not required in New York and Illinois, physicians do have to do a retrospective review of 10 charts per month, or 5% of the PA medical records for the year, and sign off on those charts as a kind of retrospective QI. In all of these areas, PAs are able to kind of prescribe the same medications that physicians are, but the actual language around the relationship between a physician and a PA is different. In Illinois, for example, it's being collaborative, whereas in New York and California, it's a supervisor role. One more thing to note is that in most places, PAs are licensed and regulated by the same medical board that physicians are. But you'll see in California that actually PAs have their own medical board that's licensing and supervising them. Let's look at some trends in APPs in emergency medicine, and I want you to kind of think about this as a future projection of what we might see kind of moving forward. In 2018, you'll see that nurse practitioners and PAs already make up over 20% of the emergency medicine workforce. They're very integrated, very much part of the teams and the care that patients receive when they arrive to an emergency department. This is a chart that is kind of showing really the 10 years after that 2004 ACGME hour limitation, the rates of APPs boomed and continued to increase, really capping or not capping, really plateauing their growth around 2016, but still at pretty high numbers of growth per year in 2018. This is a projection of the future growth of PAs and NPs as compared to physicians. The numbers will likely continue to grow. You can see in that last column that PAs and NPs will grow at a rate that's higher than physicians projected, and will continue to make up care teams, but likely have a higher percentage of the care teams that we see. Let's do a quick thing about billing. It's really hard to talk about any of these topics without understanding how the money works. So CMS billing, or Medicare and Medicaid billing, is how hospitals make their money and how most private insurances determine how to bill. So there's 3 ways that APPs bill for their time or their care. One is direct pay, which is essentially the PA or the NP billing for their care in and of itself. This makes about 85% on average of the amount that a physician would make billing for the same services. Then you have incident to and shared split expenses. These actually bill up to 100% of what the PA and NP would make. Incident to billing, we likely will not see in the emergency department. It's mostly an outpatient designation. However, some urgent cares use this to bill. And so if you're working in an urgent care, it's something to know about. Shared split expenses is where we mostly see the billing in emergency medicine. And this is essentially a PA doing primary charting, but the physician co-signing with a substantive parts of the care being taken place by the physician. That's either a history, a physical, or an MDM that is MDM, excuse me, that is documented explicitly by the physician. This may be why in some places where it is legally not required for a physician to sign a chart, that physicians are asked to sign charts at institutional levels. And of course, looking at how people are paid. So you'll see an emergency medicine in the middle there. An average emergency medicine, this is 2020, by the way, an average emergency medicine doctor makes around $250,000. The PA makes about 100, as does an NP, which are on the higher end for APP salaries. Now we're going to talk about some models of practice. So in areas where physicians are hiring APPs themselves, you have an independent contract type situation where a group or a physician will hire a specific APP to work with their group. Designated collaborator is how we generally see emergency medicine. This is both a attending physician and an APP hired by the same organization that then are designated to work together. The physician is designated to supervise or collaborate with the APP. And there are some areas where NPs are allowed to practice independently or in a collaborative agreement where the NP will hire a physician to fill that regulatory role for their practice. The types of supervision that APPs get is actually quite varied. So we have direct and indirect supervision, which is exactly what it sounds like. Direct supervision is where the attending physician sees every single patient, is presented every single patient, has the ability to examine, look at labs, do everything. Indirect supervision is different. It's more of a being available for a consultation, but not necessarily having to see every patient, or not actually seeing every patient, but still potentially signing charts. And then on-site and off-site supervision is also what it sounds like. You can have both indirect supervision with the physician in the actual setting that the APP is in, or in a completely different setting with off-site supervision available for phone calls or telemedicine. ACEP actually has a policy statement on all of this, and something to be aware of is that even ACEP will say for critical access centers and for rural medicine, off-site supervision is allowed and encouraged due to shortages in physicians. This is a study from 2018 that I found pretty fascinating. So this was essentially a survey of all of the ACEP counselors in 2018. There are 331 at this time, and 207 responded. So this is that percentage of people that responded. These are the hospitals and setting practices that use PAs and NPs for their care. 163 out of 207. What I want to call attention to is that while in Kings County, we generally see PAs and NPs seeing ESI level 4 and 5 patients in fast track, this is not the case in a majority of the rest of the country, where PAs and NPs are seeing all the way up to ESI level 1 patients, sometimes primarily. If you look at that first line, about 36% of ESI 1 patients in response to this survey were seen primarily by a PA or NP. And only half of the time are those patients actually presented to an attending in the real time. In only 16% of those patients, the physician reviews the chart after the patient leaves, leaving quite a large percentage of patients that are seen without an attending supervision in the moment. So let's talk about some medical legal cases. So this is a retrospective of 2007 to 2016 of malpractice claims. So you'll see in a majority of cases, the attending physician is co-named with the APP that is sued. That's not always the case. So in 26 and 63 respectively, the physician is not co-named, but in about 75% of these cases, the attending physician is sued at the same time as the APP. PAs get sued for in every specialty. Emergency medicine makes up about 8% of the cases during this time, with the majority being orthopedic and family medicine. And nurse practitioners make up a little bit of emergency medicine, 4% as well, but a majority is in family medicine. This is likely due to the staffing differences of PAs and NPs in the workplace. Why do APPs get sued? Most often it's diagnosis related. This is actually the same reason physicians get sued. We miss a diagnosis, or we do the wrong diagnosis. You give the wrong treatment, or you do improper medication management. And then on the bottom are more surgical and outpatient things that PAs and NPs get sued for. So how are doctors held liable for these cases? There's a term called vicarious liability for negligence. Now, this is essentially saying that one person can be held liable or responsible for another person if there's a relationship between them. So the kind of term in the law is respondent superior, essentially meaning let the master answer. If you are in a supervisory role over somebody else and they do something wrong, or there is negligence in the case, this is what's often used to co-name or sue a physician for malpractice. Now, people may or may not know this, but there's actually 4 elements to every malpractice case of negligence that need to be met. So one is a duty, so it's actually a duty to care for the patient. There's a breach of the standard of care, what your peers might do. There is a causation of some kind, whereas the actions of one actually specifically led to the harm of the patient. And then there is the actual harm, or the actual damages that the patient suffered. A spinoff, or kind of a subsidiary of vicarious liability for negligence, is agency theory. And this holds that if there appears to be a relationship between 2 individuals, you can use vicarious liability for negligence to sue. So in this case, it's often used where a physician may not sign the charts, but is supposed to be supervising and can then have vicarious liability for negligence through agency theory. You also have direct liability for negligent supervision. This is often used if a physician has co-signed, has seen the chart, and then there is still some aspect of malpractice that occurs. The best quote that I found for this was actually a lawyer who said, "You may delegate the history taking to one of these providers, but you have not designated the liability." And then finally, we have direct liability for negligent hiring and credentialing. Probably will not have to deal with this in most of our cases, but if you are the one specifically credentialing and specifically hiring PAs and NPs, and there is something abnormal or wrong about the credentialing process, you can also be sued for that. So let's look back at those cases now that we have kind of a foundation and a primer for how APPs are treated and how physicians may be held liable. So as a reminder, we have case 1. This is the 2-year-old boy who died from pneumonia. The physician did not see the patient and did not sign the charts. This was in Pennsylvania, where a co-signature requirement is not 100% for every case. There is a supervisor role of the MD to the PA, and indirect supervision is allowed, meaning not every patient needs to be seen by the physician. Both providers were held liable in this case. Using the principle of agency theory, the physician was held responsible for the PA, even though the that PD did not present to the MD, essentially meaning you don't have to sign a chart to still be held liable for these types of cases. Case 2, misendocarditis. This is the young man who died from not getting antibiotics after a root canal. And as a reminder, the MD did sign this chart. The case was done in Wisconsin, where there's no signature requirement. It's again a supervisory role, and indirect supervision is allowed. In this case, as it was kind of reviewed during the case, it turns out that the MD was only reviewing the chief complaints and the PA recommendations, but not reading every word of the charts. This was settled for $1.2 million for wrongful death, with both the MD and the PA being held responsible. Case number 3, this is Pneumonia. This was in Maryland. This is the young man that complained of cough and fever. The MD did not see the patient. The MD did not sign the charts, and he came back 12 hours later to be intubated for respiratory failure in the setting of multilobar pneumonia. In Maryland, again, there's no co-signature requirements. It's a supervisory role. The Maryland law is that indirect supervision is allowed, but you have to be available for direct supervision if necessary. This was also held liable for both the physician and the PA, even though the physician did not see this patient. Case number 4, the missed appendicitis, also in Maryland. This was one where the physician examined and documented on the patient, but had the missed case of leukocytosis. This is a pretty classic example of direct liability for negligent supervision, where both the physician and the PA were held responsible. And finally, we have case number 5, our missed appendicitis, where the NP saw the patient primarily. This is in Alabama, where NPs are allowed to have independent practice. However, can consult physicians if necessary. Now, this one went to trial, and as a nice ending, the physician was not held liable in this case. The jury determined that the NP used poor judgment in and of itself in not consulting the physician earlier, and it was not actually a case of inappropriate supervision, but rather inappropriate judgment by the NP. Everyone take a breath. Those are scary cases. It gives me palpitations going into the work field, knowing that these things exist and this precedent exists for lots of cases. So let's talk about what we can do. So most important is always communication and setting clear expectations for how you're going to work with these providers. Maybe in the beginning, you want to see every single patient like a resident would. Maybe you want to be able to make yourself available for every patient, but you need to be able to find a way to be comfortable in dealing with patients in these kind of coordination of care teams. It's very important to understand the local policies, not only the laws of the state, but also what your own institution wants and why those things are the way that they are. You have to know who to talk to if you feel uncomfortable, who to kind of escalate issues to, and also kind of decide how your own practice can meld into what the institution wants. And as always, for every patient, not just these, it's important to document really carefully and thoughtfully, and read charts and document appropriately. So in summary, APPs are going to be a part of emergency medicine. I hope that those trends and those charts show that they're not going to go away. They're going to be part of our care teams, most likely forever. As a physician, you have liability that's different when working with APPs than when you see patients primarily. And it's really important to learn how to lead and collaborate these teams. Some references, and of course, some thank yous as a senior lecturer. Thank you to Dr. Willis and our APDs holding our ship together through the last 4 years that I've been here. A special thank you to my mentors, Dr. Sorrells, who's here, Dr. Youssef and Dr. Smith, who helped push me and realize my potential, not only in residency and beyond. And of course, a huge thank you to the best class, my class. From the very first day of residency to our last in-service exam, we've really helped each other up. We've gotten some really rough times through a pandemic for multiple years. but we always took the time to celebrate and choose those opportunities to be with each other. Thank you guys so much. I'm so excited to see where you all go. 4 years later, feels like 20 years older. It's been quite a ride, and I am so excited to have gone through it with you all. Thank you guys so much.